So the therapeutic stance. The clinician does not bring presumptions about drug use. This means the clinician does not take a stance on whether the person should stop. And drugs are not seen in that good-bad dichotomy. It is not relevant or helpful for the clinician to have a stance on drugs. What is much more meaningful is for the client to evaluate, are the drugs they are doing a fit for them? We'll touch on this a bit more in the next slide. But by standing outside of the client's internal conflict to use or not, we model for the client how to stand outside of it. This allows them to think more deeply about their own experience and not latch further on to that good-bad dichotomy. From us, what is required is true openness, patience, and being free from judgment. Ideally, we are operating from a stance of objective curiosity, which hopefully becomes a stance that the clients are able to take over time. We must also get very, very comfortable with ambivalence and hold that thought because we're going to return to that in a moment. But first, I want to talk about substance neutrality. Substance neutrality builds on the idea that the clinician does not bring presumptions about drug use. However, this takes it a step further, and we do not distinguish between good drugs and bad drugs. In harm reduction, we do not make that distinction. Those types of distinctions further this stigma, not just around drugs, but around the people who do them. If we accept the label that some drugs are bad, what does that say about the people who choose to do them? How does that shift how we think about that person? Substance neutrality is breaking away from the idea that marijuana is a good drug, or that psychedelics are a superior drug, or that heroin is a bad drug. All psychoactive drugs have benefits and risks. Now, their benefit and risk profile may differ, but it's simplistic and stigmatizing to work within the good-bad construct. Additionally, if we say that marijuana or psilocybin mushrooms are good or not harmful, and on the other hand, we say meth and heroin are bad, we're potentially condoning the use of some drugs while creating a stance of judgment for others, something that is not therapeutically beneficial to our clients. Building on substance neutrality is intention neutrality. We've latched on to this idea that drinking for taste is more noble than drinking for a buzz, that using a drug to have a transcendent experience is more acceptable than using a drug because it feels good. It's important we don't pathologize a person's need or a person's experience. Expanding your mind, minimizing pain, feeling good, having fun, dancing all night, feeling less like yourself, forgetting your problems, having a more robust erection, having more energy, detaching from one's life, to me, are all equally valid reasons for using a drug. I don't treat people differently for what they use and why they use it. Because as soon as I do, I'm no longer being open. I'm no longer being non-judgmental. I'm no longer attuned with them and connecting with them. In addiction, ambivalence is often considered a sign of denial or a lack of motivation. This is rarely accurate and almost never helpful. Ambivalence is usually the sign of a functioning brain that's capable of seeing the gray areas around issues that are really complex. And our role as therapists is not to simplify someone's ambivalence by only addressing one side of it, but rather to help them explore the harms and the benefits of their use to more fully understand their relationship to substances. Clients often work well when tension is maintained between what they like about their substances and the negative consequences they suffer. It's helpful for clients to keep exploring that relationship, and we can support that by modeling curiosity and resisting premature conclusions. So we've all been there. Maybe we eat too much. Maybe we're in not so great of a relationship or in a job that makes us unhappy. There's always a reason to stay and always a reason to go. There's always a reason to change, and there's always a reason not to. We often need time and ideally support to make those decisions and make plans for those decisions. And it's the same for our clients. Often ambivalence partially stems from the lack of clarity around their substance use. And for this, the continuum of use can be helpful. The continuum of use is not a diagnostic tool. It's a way for people to identify how they see their use. Far too often, we see addiction through the lens of a binary construct. Someone uses or they don't. They have a problem or they don't. When we operate as if people were only at the ends of the continuum, then we miss a whole host of nuances and complexities that may be happening in the middle. So as you're looking at the continuum, you see it starts at 0 or no use. So that refers to total abstinence. Experimentation is when drugs or alcohol are tried at various times. Social or recreational use implies that use kind of occurs in the context of fun or relaxation or social situations. Habitual implies a pattern has emerged. Maybe that's smoking marijuana daily, going to happy hour every Thursday, doing cocaine every weekend. Abuse is often use that has become habitual, plus negative consequences that aren't really stopping the use. And then we have dependence or addiction, and this may or may not include number 6. One does not have to have physiological dependence to meet criteria for a substance use disorder. Further, physiological dependence can occur completely outside the context of addiction, such as experiencing things like tolerance and withdrawal from a medical prescription. And then finally, the last one on the continuum, we have persistent addiction. And that's that really deeply entrenched, wildly chaotic experience of addiction. I like to review the continuum with clients and ask where they see their use. And sometimes I get really funny answers. Someone will be like, I'm a 3.9. But beyond where they are, we can use the continuum to help them gain clarity about where they want to be. Because in harm reduction, we aren't presuming that everyone has abstinence as their goal. Additionally, this tool can help people distinguish between their use patterns with various substances. So let's say a person uses cocaine, alcohol, and marijuana. They may see their marijuana use as habitual, cocaine as social, and alcohol as abuse. Thus, their goals may include shifting marijuana to no use, moving alcohol to habitual, and keeping cocaine as social. Now, that person may not be at abstinence, but they likely made some changes that were important to them. If you notice on the continuum of use, the arrows go in both directions. The continuum is not an inherent linear progression. Progression from use to dependence is not inevitable. Remember, back to our second module, the vast majority of people who use substances will not become addicted to them. The simple notion that someone uses drugs is automatically not cause for concern, especially if they're well informed and they know how to take steps that lead to safer use. Another thing to consider is that use may be temporarily problematic. So let's use a non-drug example for this one. Say we have a client going through a complicated grief process. And through this, the person has been using food to help cope with overwhelmingly painful emotions. They've stopped engaging as much socially, and they aren't participating in their interests the way they did before. However, the eating has become more prevalent, and they've gained a noticeable amount of weight in a relatively short period of time. Most of us would not necessarily assume this person has an eating disorder. We probably would not think they needed any special treatment in an inpatient setting. We wouldn't think, oh no, this can only get worse and more dangerous and they're probably going to have a heart attack and die. On the contrary, we would likely see it as a reasonable way to try to feel better in a horrible situation. We would see the change in their eating patterns as a response to grief. And our work would largely revolve around the grief and helping them to find more beneficial ways to manage their pain, to help them navigate the disorientation that comes with loss. Yet if we change out the food for drugs or alcohol in that example, often people let go of grief as the real issue and change all the focus to addressing the substance use. Which brings us to an important point. It's critical that we develop a needs hierarchy from the client perspective. If the client chooses to address a work issue rather than the substance use, that's okay. We can start there. Now, I might begin looking for connections between the two issues, but when I discuss this with the client will be determined by trust, rapport, and client readiness. Because when clients are met where they are, resistance often goes down. My role is to provide information and expertise that may help the client determine their priorities. I was contacted by a man who was newly sober from alcohol, and he wanted support in maintaining that. However, during the consultation, he also brought up burnout from his job, issues with his fiance, and some complicated family of origin issues. I clarified at the end of the session what he wanted to work on, and he expressed gratitude for me asking. He said, I don't want to just be seen as an alcoholic or a person in recovery, because I'm more than that. We must consistently acknowledge our own limitations when it comes to knowing what another person needs in their daily life. We must consistently place value on the client's perceptions of their needs, their resources, and values when it comes to prioritization. Clients are especially motivated when they are granted the freedom to address issues from their perspective of importance rather than mine. People who are actively using can and do participate in treatment. And it's the interactions between the client and the therapist that create an environment in which change is possible, especially when we frame things like, tell me how you see your problems. And when we avoid confrontation, when we avoid those quick fix solutions. Terms like denial and lack of motivation are generally inaccurate and almost always unhelpful. It's natural to hide certain traits when they're being judged or when we worry we'll be pushed into a change we aren't ready to make. By engaging collaboratively and curiously, this is often minimized. Certainly, there may be occasions in which use does become an impediment to therapy. However, clients are generally more accepting of this if they've been given an opportunity to participate. When clinicians maintain a no-using policy during treatment, it ceases to be person-centered or informed by actual client involvement. And in our next segment, we'll pick up by debunking a really dangerous myth.